members of our research team here to share some updates on that. We will be recording the session today. So if you don't want to be seen on screen, feel free to just remove yourself on camera. If you do have any questions, please. Oh. A little tweak here. There we go. If you do have any questions, please feel free to pop them in the chat. Our team will be monitoring them, and we will get to those near the end of the presentation. So before we get started, I just wanted to start us off on a good way and acknowledge that today, with gratitude, we are gathered on the traditional, ancestral, and unceded territories of many BC First Nations who have cared and nurtured for this land for all time, and give thanks for allowing us as visitors to live, work, and care together. We acknowledge that there are other Indigenous peoples that live on these lands that originate from their own respective territories outside of these lands, including the chartered communities of Métis Nation, BC, and the Inuit. Today, I'm coming to you from the Katzie Nation, colloquially known as Surrey, BC. And before we get started, I do just want to do some brief introductions for anybody who hasn't had the opportunity to meet our team, as well as members of our research team. So my name is Steph. I'm a registered psychiatric nurse, and I'm the team lead and consultation nurse for the Transition and Linking to Care team, which is the team involved with the Missing Middle program. And I'll pass it over to my colleague Otto to introduce himself.
Hi, everyone. I'm Otto Lim. I'm a social worker with the TLC team. And over to Sarah.
Hi, everyone. I'm Sarah. I use she, her pronouns, and I'm also on the Transition and Linking to Care team with the Missing Middle program, and I'm an OT by background.
And we'll throw it over to Sage from the research team to introduce themselves.
Hi, everyone. My name is Sage. I use she and they pronouns. I'm coming from the Lekwungen-speaking territories, otherwise known as Victoria. And I am a research manager at the University of Victoria, and part of the research team for this project.
So, all right, so just a little bit of background for anybody who may not be familiar with the Missing Middle before the kind of the impetus of this program. So the Missing Middle, and just some background demographics to kind of set the tone for why this program was initially created. So demographics across the world, we know that people ages 10 to 24 make up about 25% of the world's population. We also know that adolescents and young adults have a higher need, but the poorest access to timely and high quality mental health and substance use care. And when we think about the onset of mental health conditions or mental health symptoms or concerns, whether that's a diagnosis or just symptoms, we know that 50% of mental health disorders begin before the age of 15, and anywhere from 63 to 75% of mental health conditions emerge by the age of 25. So this is quite significant when you think about how they make up about 25% of the population, and most of the mental health symptoms and diagnoses will occur before they reach adulthood. So prevalence, about 50% of young people will experience a mental health disorder by the age of 25. And we know that mental health and mental ill health accounts for roughly 45% of the total disease burden among those aged 10 to 24. So when you think about medical concerns, injuries, things like that, mental health makes up almost 50% of these concerns in this age range. So we know that from research, and a lot of research is being done, especially in Canada, to understand child and youth mental health, as well as the mental health of young adults. But growing research shows that in many countries, the mental health of young adults has been steadily worsening over the past 20 years. And of course, there was a significant rise in mental health problems when COVID began in 2019 and 2020 due to many different factors, including restrictions, and there are many lasting effects that we're still seeing to this day for young people. Without effective treatment, mental health can lead to early death through physical health problems as well as suicide. And even when not fatal, they remain the leading cause and fastest growing contributors to disability, reduced potential, and loss of productivity through life. So that's really kind of some background information just to understand why this initial project and now program was started. So the missing middle refers to a gap in care for transition age youth. So specifically 16 to 24 years old with moderate mental health concerns. So these people are often deemed too unwell for primary care. So programs like Foundry, integrated child and youth programs, walk-in clinics, family doctors, NP offices, but they're not unwell enough to require hospital inpatient services or tertiary services. So really, when we're talking about acuity, it's really that missing, the moderate in the middle there. So these young people with really nowhere else to go will often present to the emergency department because they struggle to access and stay connected to services, particularly between the transition from child and youth to adult services. And we know that a lot of these services do have different age requirements depending on the region. So sometimes it will be at 18, 19, 21. So this can become really difficult for system navigation as well. And just a side note, we know that these challenges are also disproportionately affecting youth that are facing structural inequalities, including racialized youth and those who are using substances, as well as Indigenous and 2S LGBTQIA plus youth. So this is just a graphic here to show really, so when we're talking about the mild mental health, programs like Foundry and family doctors and NPs and primary care really can meet that need. And we have a lot of services that look at severe mental ill health. We have inpatient services, we have tertiary services, we have mental health teams, adult mental health teams like the ACT team, access teams. But really, when we think about the moderate, they're really put in between those services, when in reality, they're both supposed to be covering moderate, so mild to moderate mental health, and moderate to severe. But often these people in the missing middle will not get access to services because they don't meet the criteria. A little bit more background. So this age group between the age of 16 and 24 is particularly vulnerable to mental health challenges. Many young people seek mental health services, especially those in the transitional phase, so between 16 and 24, which is often marked by a difficult shift from child to adult mental health care. These are some statistics from research that we use for background on the missing middle. So like I said earlier, roughly 63 to 75% of mental illnesses will present before the age of 25. Another interesting fact is that about 50% of people drop out of mental health and or substance use services at entry to adult services. So when they do transition from child and youth services to adult services, one in two people will drop out of the services because they're likely not meeting their need, or they're not youth informed, or they have many barriers to access these services. And we also know that 25% of young people who need mental health or substance use services actually get the appropriate level of care they need within Canada. So there's quite a large portion of young people who are not having their needs met by the current mental health system. And just a little bit more about background. So when we think of the missing middle, we think of transitions for 16 to 24-year-olds. We think about a lot of things that are going on at this time. So yes, we talked about mental health, whether that's symptoms or diagnosis, but we also think about personal transitions. So identifying who they are, what their goals are, who they want to be, interpersonal goals and transitions. So family dynamics, so transitioning away from the family, moving towards relationships, friendships, and adulthood. So these are all a lot of things that could be happening at the same time. And when you add a mental health concern on top of that, it can be really difficult to move through this stage. So at this peak of age of onset, so between 16 and 24, we see the highest burden of mental ill health, but the system is at its weakest and most fractured. So we have all of these transitions happening in our personal life, and then we also have transitions that are mandatory through the age requirements and requirements for mental health services. So this can lead to difficult transitions that jeopardize life trajectories of young people as well as their families. So they're not able to transition successfully. So this is really the impetus for our project and wanting to smoothen these transitions and support young people and their families to get better access to care and the care that they need. So I'm going to hand it over to Otto, who's now going to talk about some of our education and how we do this as the transition and linking to care team.
Thank you, Steph. So really the mission and what's important for the Missing Middle and the TLC team is to help build capacity in the mental health and substance use services to better engage and work with young people. So we attempt to do that through providing education. So in the last year, we provided a number of workshops, and the first three, navigating borderline personality disorder traits in young people, exploring transitions and eating disorders for young people, and the chronic middle, cannabis, anxiety, and mood in young people. Those were workshops where we started to feature the voice and the experience of young people with lived experience of those issues. And what we've heard really clearly in the research in the community of youth mental health, it's so important to include the voices of young people with lived experience and family members and caregivers. So in the future, as we move on in our education series, we hope to continue to feature the lived experience of young people, family members, and caregivers. And then a couple of other presentations we did was on special issues. One was on harm reduction approach to technology use. The other one is managing loneliness in young people. And those are issues that really are quite integrative and significant for young people when we do work with them and we try to understand their context. And then the other ones we've provided in the past is around family-centered care, discharge and safety planning. So really around looking at the best ways to promote resourcing and transferring of care, transition planning and resource connection. We know there's lots of resources as youth enter and leave child and youth to adult system, and demystifying working with young people. And those also coincide with our provincial education online education, and they're free modules that are developed for healthcare providers in BC. And we've launched officially Module 1, so kind of a clap because it's been quite a bit of work. So you can access this. Demystifying Working with Young People is launched in September 2025. The second module, Family and Community-Centered Care, will be launching soon. We're just in the final process of that. And then Module 3 is in development, continuity of care, including discharge and transition planning. Module 4 is working with neurodivergent populations. And this is something that the TLC team will be working on to provide a workshop on how to work with neurodivergent youth. And then the last one is common presentations in youth in mental health and substance use. And another part of what we do with the TLC team is we often will consult with care providers in the system when they might have a particular young person or situation that we can support. And so these are some themes that came out of the consultations or case studies we've been involved with. One is transition planning, handovers, and protocols. So really, the idea is to support a smooth transition as much as possible for the young person. We've also addressed the age cutoffs where there might be a young person that is over 19, but functionally they might need the supports of the wraparound services of child and youth. That there's lots of issues and need for engagement and support for neurodivergent youth, especially as they age into the adult system. Also, how to work with young people to engage them, and sometimes when they might be anxious or apprehensive about accepting care. How to include families, communicating with families, and navigating confidentiality challenges. We've also looked at how to collaborate across allied health programs and staff to promote continuity of care. As many of you know, there's lots of different health authorities, boundaries, programs, criteria. Trying to deal with the resource discontinuity. As we know, when youth age out at 19, there's changes around MCFD funding and supports, housing, and eligibility criteria. There's also gaps in inconsistent expectations and guidelines around services and resources, including inequities in medical, legal, and health systems, especially from people with developmental transitions, where we've heard from a number of young people and providers when they graduate or transition from school or perhaps from housing. There's also a number of youth where there's a risk of suicidality and self-harm and safety planning, as well as co-occurring medical or health issues that young people might have. And lastly, how to support and navigate around resources for academic or vocational support needs.
Thanks, Otto. So as Otto mentioned, we are really working to embed lived experience and living experience into all of this work that we do. And so we are really aiming to listen to and elevate lived and living experience voices, not only of young people, but also their caregivers and their healthcare providers. So we've hosted several engagement sessions with missing middle young people, as well as caregivers, family members. Our research partner, who you'll hear from in a moment, Sage, will talk more about how our research interviews with and clinicians who have experience with the missing middle, and they have some ongoing studies happening. So I'm really excited to hear from Sage about that and some ways that some people might be able to get involved or spread the word. This year, we developed the Youth Action and Change Circle. So it's our version of a youth advisory committee, but our youth wanted the name to more around action about pushing for change. So this is a partnership with our research partners at UBC and UVic, and it's a circle of youth advocates aged 16 to 26 across BC with lived or living experience of mental health and substance use. Many or most of them identify as being missing middle young people at one stage in their lives, or potentially still. And we are also in the process of developing a family advisory committee, which we are really, really excited about. So just to ground us in this work, I wanted to quickly share with you from our Youth Action and Change Circle, we asked them what were some things they wanted healthcare providers to know about the missing middle when we were planning on giving this talk specifically. And for any of you who joined our young adult panel last week, we did have 3 young people with lived experience talking about this more in depth. So we really recommend folks check out the recording and the slides for that if they weren't able to attend. And once we're done going through these 2 slides, I will just ask everyone to do a bit of a chat blast if there are things that they're really taking away from this or big things that are hitting them from the Youth Action and Change Circle. So as you're listening, feel free to keep in mind if there are any nuggets that you particularly really appreciate. So they've said that it's important to consider and talk about all the transitions they are going through in their life. Understand that the transition to adult services is jarring and youth may need front loading and preparation. They talked a lot about how being on an adult psychiatric unit can be very scary for a youth or an adult when there might not be a specific unit that might meet their needs in their region. It can be hard for young people with trauma or PTSD to get the right support. They talked about how a lot of clinicians do not want to touch trauma, or they might be told in their mandate that they're not able to, right? But youth might not qualify for those higher level services or have resources to pay privately for that really in-depth trauma counseling. And a lot of them felt like their recovery journey could have started earlier if teams had more resources to support trauma with the young people that were coming in. Teams also need more resources, education, and flexible mandates for supporting complex youth. This is something we hear from the YAC a lot. Things like multiple diagnoses, neurodivergence, substance use, or social or housing issues. We've also had a lot of young people say that they have not been able to qualify for a treatment program if they have two things going on at once. And for any of us here that work in mental health and substance use, we know it's very rarely a person with just one thing going on, right? As humans, we're complex and multifaceted. And so say someone had substance use and an eating disorder, it might be that they can only work on one of those things while in treatment, or they might not even qualify for treatment if they have one of those other things going on. So just a quote here. Not everyone can get care from Foundry. There may not be one in their area, it might not have access to psychiatry, or they may have too high of needs. This means that the adult services they are accessing are not as youth-friendly and low barrier. Again, a big thing we've talked about with that missing middle range of the continuum, where Foundry services have been mostly developed for mild to moderate, and some of these young people might not qualify for those moderate to severe services out there. And the last question we asked the YAC was, how can healthcare providers offer more autonomy to young people going through mental health and substance use treatment? A big thing we heard again and again was to explain the why of a recommendation. This goes for people on inpatient units, but also for those who might just be working one-on-one with a young person, right? Educate them on why this is important instead of just saying, oh, you know, you should do this. Especially in some settings where there's a power imbalance, it might often be that they're being told to do something because they might get more privileges if they do, like they'll be able to go on passes more if they start coming to groups and things like that. Supporting family involvement, but doing it on a young person's terms. We know family involvement is such a crucial point of ways for a young person to access support, but there is a certain amount of confidentiality that you have. Parents don't have to be involved in every meeting, and you can have your own choices. This often will also make a young person more comfortable and wanting to open up to their clinician because they know that not everything is getting shared with their families, and it's something that they can really have ownership about with their provider. And then being flexible and open to feedback on schedules for residential or inpatient units. So if any of you can relate to me, I've sometimes worried when I've worked on inpatient settings, like, do we have enough going on, right? And there is too much idle time, but there can also be times where maybe we're not allowing enough space and time for the flexibility of what a young person needs. So a quote here, being told what to do all day made me feel like a robot. Not like I was being assisted or helped, but that I was being forced into a position. It didn't make me feel like I had control or choice. What the YAC recommend to be able to circumvent that a bit is to not have the schedule be too packed. You want to have some structure in there to support them, but ensuring there's downtime so they can rest, decompress, or do their own thing. And while going to groups and structure is valuable, and of course we want to encourage young people to do so, respecting their decisions when they may not always be up for going, right? Sometimes it's just not the right day, not the right time. And a quote here is, you should be able to take time for yourself when you need it, not just when it's scheduled in. And the last thing I said about this was offering choice as much as possible. So actually seeking ideas from the youth on the unit about groups and seeing if there's something that they really enjoy in their daily routine at home that would help them feel more at home while they're in hospital or in an inpatient setting. So that was a bit from our youth advisory, from our action and change circle. I just wanted to stop here, and if everyone is able to, in the chat box, just to open it up and start writing a message, but don't hit send just yet. And then in about 20-30 seconds, I'll ask everyone to send them in at the same time for a chat blast, just to hear what have been, from what you've heard from the YAC here, what is the thing that stuck with you the most, a main takeaway or something that you found quite powerful that you just learned from them. So I'll give everyone about 30 seconds. And I'll give about 10 more seconds, and then everyone can hit send at the same time and send those in. Okay, feel free to send those responses in. Yeah, not being able to access care as a whole person, but siloed by diagnosis or denied altogether for having complex needs. Definitely. Wraparound services and youth having a voice to decide for themselves. You should be able to take time for yourself when you need it, not when it's scheduled. Love the emphasis on really collaborating with youth, not telling them what to do. I love the idea of having youth with lived or living experience share their thoughts and experience with us so that we can help improve services for the missing middle. And offering choice as much as possible. Thank you so much, everyone, for those reflections. And I will pass things over to Sage to talk more about research.
Thanks. Hi, everyone. Yeah, so I just wanted to really highlight a few things today. And one of the things that I'll be talking about besides the research study that we're doing, I'll also be chatting a little bit about some findings that we had from a missing middle concept paper that we put together. So the next few slides are kind of going to go through the concept of missing middle that we've identified in this paper. So first and foremost, just to rehash this definition that we've kind of been talking about, but more specific, the definition that we shared in this paper is the missing middle is a gap in service delivery that exists at a systems level where services are provided to support those at either extreme of service needs and neglects those who fall in between. Thus, anyone can find themselves in the missing middle. So yeah, just bringing us back to that. Yeah, so from this definition, we sort of identified how there's these zones of access that we've coined this term. So this is just a schematic to really show what falls into those zones of access, as well as how they relate to each other. And it just kind of really highlights what the gaps are for this missing middle area. I won't go through all of this just because, but just, yeah, seeing how acute care, obviously there's hospitalization, emergency rooms, community supports, like informal and informal supports within that. So resources within the community. And yeah, just how the missing middle can show these gaps and have these barriers where things are not necessarily helpful or needed on either side of the missing middle. One thing I did want to highlight, though, that I feel like is very important to note is just that point within the community supports, where these supports, there's this felt sense for youth or young people that these supports are meeting this person where they're at and they're, found to be helpful and sufficient. And I just feel like that felt sense is so important because, we can talk about something that is kind of this concept and sort of this cerebral thing, but really bringing in what this experience is really like for somebody while they're going through the missing middle. So yeah, just wanted to highlight that. And it kind of helps with this next slide, which shows a little bit of a vignette, a story, if you will, of what it's like navigating this. So I'm going to walk through this story. This is Casey's story, and as I kind of tell it, you'll see how there's these points on that what the experience is like. And I just wanted to preface, though, that this is just a snapshot of one person's experience. So it's certainly not like their story continues before and will continue after. So it's definitely not just like, yeah, just a snapshot. So thought I should say that. But so Casey's experience with mental health started when they were a child. They grew up in a small town and felt that there were not really conversations around mental health, that there was a lot of stigma, and they just didn't feel like they had any conversations around coping skills. As a young person, they chose to move to a larger city and pursue university. While pursuing university, they kind of felt as though they were having some struggles and having some mental health challenges and changes. So the first sort of place they felt comfortable to go to, or knew that they could go to, I should say, was like the student health center on campus. So that's where you see point one. They started by seeing a general physician that they were able to access, and through that experience, they were able to get some psychiatric medication prescribed to them. But this really was really what they called kind of ramping up occurred. So they felt like the medication wasn't really helping, and they were also facing mounting struggles being in school and just being away from their community and their family. And so that's where we kind of see them kind of going into that missing middle experience. And these struggles and just not feeling supported with their medication ultimately led to them attempting suicide and leading to their first experience with emergency services, taking them to the emergency room. While at the emergency room, they had this experience where they really felt invalidated by the staff and the healthcare providers, and they just didn't feel comfortable being there. And they really, really were in this experience of, okay, I don't feel comfortable being here, and I don't feel safe to go back home. But it ultimately led them to lying about what they were experiencing so that they could leave the emergency room, because ultimately they felt the emergency room was the lesser of the safe places for them to be. So that just kind of was their first experience where they were navigating this missing middle, they're oscillating between the hospitalization and the emergency room, and then the services at the student health center. So yeah, this is sort of where we start to see another experience of this missing middle, where these services are not accurate, or not well suited to what they need, and then what they are currently accessing is just not enough. So this really spurred them to connect with their family, and that sort of informal mental health support was a big help for them. They also accessed a referral to a counselor and a psychiatrist from the GP at the health center. And so they were at this time at 0.5, I should say, connecting with a counselor by paying out of pocket. And, those things were helpful and provided some support for them, but they were still on the wait list for psychiatrists, and they were not accessing the medication needs that they needed, or like more fulsome supports that they needed at that point. And they then felt like with surmounting challenges with work struggles and different things, they were just really not feeling safe again. And we kind of see this feeling again of where things are ramping up and just not getting the supports that they need, enough of the support that they need, I should say. And so what ended up happening for Casey is ultimately they were at a counselor's appointment one day. They were describing the feelings that they were experiencing, and the counselor ultimately said to them, from what I'm hearing, the counselor suggested that they should go to the hospital. So they suggested an overnight admission, that this would basically help to speed up the process in which they were waiting for a psychiatrist. So Casey obviously had this previous experience of being at a hospital and mentioned how unsafe that felt. So, but ultimately did agree that feeling like this overnight admission would be the way to do this. So, this is when we see this 0.7 come into play, where they're staying at the hospital overnight, and then through this experience, they're able to get a referral to a psychiatrist, and they were able to get a referral to other supports like a mental health day program as well. And then for the sort of the next little part from 8 to 10, we see this real navigation of the missing middle, where, they were eventually able to access a psychiatrist, but they were still facing this navigation of medication changes, and they were still waiting for some of the supports that they were referred to, and really just this kind of curve and experience of navigating the missing middle. And when we talked to Casey, they were feeling like they they had eventually at that point had been able to access the mental health day program, and they felt that the services that they had accessed were fulsome and really helpful, and they had felt they had been feeling stability. However, they reflected about how unfair it was and how difficult it was that they had to go to the hospital and have that overnight admission first before they could even access these supports, and that it just didn't seem that right for them to have to have been in this like state of crisis before they were able to access these supports, and but still having to go through that experience where it wasn't just get the supports and then I'm okay. It was all a long kind of experience of still waiting and navigating the challenges that sort of the missing middle experience exemplifies. So yeah, and I will now pass it over to the team to kind of talk through how their team will support at different points in an example like this one.
So much, Sage. So what we're going to do is we're not going to talk about every single point in Casey's journey, but we did want to highlight 3 different areas just to really show kind of what the transition linking to care team does, and how at these specific points there might have been an opportunity to maybe change the trajectory a bit or the experience. We're going to talk about the emergency room visit. So we know that this population will often, without being able to access primary care services or feeling like they're too unwell to access them, they may end up entering the emergency department. So that could be by ambulance, that could be walk-in, that could be by police. And usually it is really in that crisis state. So these often will result in poor experiences, like Casey's story about feeling invalidated, having to wait, and a lot of fear that's coming up, especially when you're in crisis. We know that emergency departments are not the most ideal situation for anybody that's in a mental health or substance use crisis. So really what the transition and linking to care team does for this population is as we are healthcare provider facing, there's a really big opportunity for emergency room staff to provide a really positive experience for Casey and other people in the missing middle. So the goal here is to have a positive experience so that if they are in crisis again, they're more willing to come back voluntarily. That's something that we always young people when they are accessing services. We don't want people to have to come back forcefully. We want them to feel like it was their decision, because we know for mental health trajectories that this often results in an improved outcome. So what the transition and linking to care team does, as Otto mentioned, is we do provide education to healthcare providers. That includes our work at Richmond Hospital with the emergency care staff, as well as other hospital staff. And we provide our education in person or virtually, and do at the elbow support. So observing practices, providing feedback, and also case consultation. So this can be case consultation in the moment, so right as a patient is interacting with a healthcare provider, or it could be after the fact where a healthcare provider comes to us and says, hey, I had this situation the other day, X, Y, and Z happened. I feel like it didn't go as well as I'd hoped. Like, do you have any recommendations for me the next time either I see this patient, or if they come in again, or if someone similar comes in, how can I handle that situation? And so what we do with us, the 3 of us, we put together some resources that would apply to this situation and maybe provide some recommendations for ways to improve their practice. For that, once again, the ultimate goal being that people have a positive experience and that they can come back willingly and voluntarily if they need to. And I'm going to hand it over to Otto, who's going to talk about the next point here. So navigating medication changes and waiting for supports, point 9.
Thanks, Steph. So we don't, the TLC team, obviously we don't have a lot of involvement around medication, but what we try to support is more the understanding from the youth and perhaps family around more what the purpose of medication is, or maybe providing some information in a very youth-friendly information so they can understand how it might relate to their diagnosis or their symptoms, or what they can expect. And the other thing we might do at this point is to really support, let's say if the young person is in hospital, is to support the hospital team to have a warm handover over into the community, to maybe help them navigate if there's some transition issues. And as we know very well, working in mental health and substance use services, there's always wait lists, and sometimes the teams might not be aware of some of the length of wait lists. So we really try to encourage um, providers to be more proactive in referrals. The other thing we'll do to support the continuity of care is to provide teams and clinicians perhaps specific information or consultations. We might even have a phone conversation around some of the challenges or youth-specific they're addressing with their client or patient. So sometimes it might be around neurodivergent needs. It might be around youth and family supports. It might be around engagement or conversations around substance use. So these are some of the things we've done to support youth and care providers at this point. And I'll pass it over to Sarah.
Thanks, Otto. So mine will be quite a bit briefer than those last two, but in terms of that last point on 10, when someone is trying to access services and find a huge part of this, as well as we know we don't want to only help with band-aid solutions if there are very real changes that need to happen in our systems. And so a large part of the research being done and what we're hearing on the ground from case consultations is also helping us understand where there are system changes that are likely more needed. And how we can raise awareness or help advocate for those system changes. One particular thing is within our research, as we do kind of hear more about the research findings, we may be able to recommend some new service options, which could be considered for meeting the needs of this group if with the existing systems and services we have, there are some gaps where there are some services missing for these youth and young adults in the missing middle. So that's another aspect of the research that our team is considering. And we're always trying to connect the capacity building on the ground with possible system changes that can better support clinicians as well.
Yeah, and just to sort of share a little bit in terms of our research findings, but also share the experience of what the missing middle is like for families, because the missing middle is not just something that young people are experiencing, it's also their family and caregivers beside them. So these are just a few like key themes that have been kind of pulled out from what we've been hearing from families. It's definitely not all of them, but just a couple that I wanted to mention here. And there's some similarities with what Sarah had mentioned that the YAC had shared as well. So that first one, where services are confusing and often siloed, only supporting one aspect of young person or family's needs, that had been mentioned previously, and just really hearing from families and caregivers about how stressful that is and confusing that is for them supporting their young person, and that often there's this felt sense sometimes also that that there's like sort of that band-aid solution to things as well, where they might be referred to something and then they find out once they get there or are able to access that thing that it actually doesn't, that they can't actually access that thing because the young person perhaps has multiple diagnoses or something, and there's like a caveat to that experience, so they can't access that thing, and just how confusing and stressful that is for family members as well, just knowing that, thinking that this is something that's going to help, and then it doesn't end up being a help. Another thing that families have talked about, and that have been kind of a stressor as well, is this in the moment care being non-existent and leading to the stress for family members supporting a young person. So this really just highlights the missing middle, in the sense that you know, if a young person and the family is supporting this young person, if the young person needs support in the moment, there really isn't any other option but to go to like a hospital or an emergency room. And obviously that's complicated because of maybe past experiences at the emergency or hospitals, but also it's just not necessarily the support that they want or need at that point, and just how challenging that can be for a family, and discouraging that can be really for family members as well. And through talking to family members, you just really hear how much they, you know, want to support their young person and want to help them, and just feeling like they're like hitting a wall or coming up against a wall when things like this are kind of happening. And Sarah also mentioned this as well, like the communication change. And, you know, it's interesting to hear for families, you know, that is a challenge and very difficult when a young person ages out. And I think we're not needing to talk about a solution necessarily, but just noting how difficult that change is, or that's maybe not known to the families that those changes can happen. So just articulating how that can be a challenge. And then lastly, yeah, just how the missing middle concept and experience really is an increased family caregiver burden, and increased advocacy on the part of the family, as well as the young person to have their care more in their hands because the supports aren't meeting their needs. And yeah, just how unfair this is. That is. So that's that. Yeah, and I just wanted to end with a little plug on the study that we are currently doing. So our study, I should have mentioned before, is called Bridging the Missing Middle, a qualitative study to improve mental health care for transition-aged youth. And we have 3 streams. So yeah, we're talking to families, young people, as well as healthcare providers. And we have conducted some focus groups, and now we're mostly doing individual interviews. And we're also having some streams within the youth within the youth streams within a stream of racialized youth as well as young people who use drugs. And we're really using this as an opportunity to highlight youth voices and the lived experience of young people in the missing middle, because it is research that hasn't been done in Canada, and really hasn't been done a lot within this area. We also are using this as an opportunity to support the missing middle team and really provide them with some information from our study and examine the impacts of the program as well. And if you're very, very kind and happy to maybe participate yourselves, there's a little screening survey thing there for you. And if you support youth, that would be also amazing. I believe we'll be sharing a little thing in the email that is sent out. So yeah, just a shameless plug. If you have time and would like to speak on what you are experiencing as a healthcare provider, or if you know that there might be some youth that you support that might be interested, there is an honorarium, and youth can also participate in a follow-up interview, which is photo voice, which is an artistic way to talk a little bit more about their experiences with mental health care. So yeah, really, really glad I could be here today and say that little plug about our study.
Thank you so much, Sage. We're going to go into the end here, but I just want to check in with my colleagues to see if there was any questions from the original poll in the beginning.
Yeah, thank you so much, Sage, for finishing it off. And I did just want to give a big shout out to our research partners. So we are partnering with a number of amazing researchers, but in particular, like Dr. Trevor Goodyear from the University of British Columbia and Dr. Ali Sleeman from the University of Victoria. We're also getting to partner with many other research folks who work with them, and some of them are on this call. So we're just very grateful to be collaborating with you on this. So thanks for being here. The question we received at the start of the session was whether we involve school districts in this program. I've just popped it in the chat as well.
So up until this point, we have not been overly involved with school districts specifically. Some people may not be aware that BC Children's actually has a schools program that does support the mental health and substance use education that schools are providing. We always want to make sure that we're staying in our lane, but that is something that's always kind of on the top of our mind, knowing that these youth often, prior to seeking emergency services, often the school is really the first point of contact. So we're not involved necessarily with school districts, but it is definitely something that we are aware of, and BC Children's is working to support as well.
Thanks, Steph. That was the only question that was submitted at the start of this session. If any other folks on the call wanted to ask questions, please feel free to pop them in the chat, as well as raise your hand. I'll also just launch our post-session poll now, just in case anyone needs to run pretty soon. So I'll just get that going as well. Just a few questions to hear feedback on how you found the session today, and if you have ideas for our team on more ways where we can have more reach with what we're doing. And I will end the recording there as well.